So to go forward, you hit the button,
Oh.
and to go backwards, you hit the red button.
Okay, great.
Thanks.
Hello, everybody. I'll be talking a bit about neutrophils and neutropenia, because I'm a physician scientist and I work with neutrophils in the laboratory, and I thought you might be interested in what these cells look like and what they're supposed to be doing. So first of all, a few words about where neutrophils fit in the array of white blood cells. Granulocytes are white blood cells that have granules. And neutrophils have these very subtle little neutrophilic granules, but their cousins, the eosinophil and basophil, are much more dramatic. And I'm sure you've all been exposed to and confused by the different names that are given to neutrophils, particularly on blood counts. They're sometimes called polys because the full name is polymorphonuclear leukocyte, which means many-shaped nucleus. Each one is a little bit different, sort of like snowflakes. That can be shortened to PMN or SEG for a segmented nucleus. And then there's the slightly not quite grown up form, the band, which is an earlier form that comes out of the bone marrow, usually at times of stress. But that's what neutrophils look like when they're squashed on a glass slide, fixed with a something like methanol and then stained. And that's not what they really look like. This is a more realistic view in 3D by scanning electron microscopy. And on the left, you see a resting neutrophil with a bunch of tiny little projections where they're feeling out the environment. But when they get activated, such as by interleukin 8, which is a chemoattractant, meaning a chemical that attracts neutrophils to come here, there's inflammation, you got to get here and fight off a bug, they get really turned on, and you can see they're actually, these are in a solution, so they're trying to go every which direction at once, which of course gets them nowhere. But in real life, there's a gradient, and they head towards the highest concentration of interleukin 8, which is the site of a nascent infection. So this is a movie, if you can start the movie, of a neutrophil in real time eating bacteria, which have been labeled with the fluorescent green proteins. So they stand out. You can see the neutrophil gets kind of confused. It doesn't know which way to go, but eventually it finds the target and eats it. And that's the job of the neutrophil, as you all know. Find bacteria, eat them, destroy them. And in fact, they're called, the other name you may have run across is phagocyte, which means a cell that eats. So this is how the bone marrow makes neutrophils. All blood cells start out from a hematopoietic, meaning blood-forming stem cell. And this makes erythrocytes, red cells, platelets, monocytes, and then the neutrophil lineage, and this colorful depiction goes from a myeloblast to a promyelocyte, myelocyte, metamyelocyte, band, and then the neutrophil. And I teach medical students that you can recognize them because the metamyelocyte is a kielbasa and a band is a frankfurter. And GCSF, which you're all familiar with, drives that production down to the neutrophil. And what you see in the blood is just a tiny proportion of the neutrophil development series. You can see that off to the right in the periphery of the body, you have blood and tissue neutrophils. They exit the blood cell, and nobody really knows how many are in the tissue. Probably depends a bit on how much inflammation is going on. But look at all of the ones back in the bone marrow. There is a storage pool of neutrophils, polymorphonuclear cells, and bands, metamyelocytes, and then there's a mitotic pool, means dividing cells that are making these cells. And in fact, one of the primary determinants of risk of infection from neutropenia is whether or not there's a storage pool of bone marrow cells that are fully mature and ready to come out into the blood. And in fact, as you'll hear more about X4's drug, mavorixafor, that's its job, to bring them out from this storage pool to the blood. What is neutropenia? You've probably all seen this definition, which is the standard one, that any absolute neutrophil count under 1,500 is neutropenia, but really in the higher ranges here, 1,000 to 1,500, even 500 to 1,000, there isn't much increased risk of infection. That then increases as the ANC goes below 500 and becomes higher below 200. And this is what many, many physicians go by. This is what's taught to residents and medical students, but it ain't necessarily so. So there are important modifiers of risk. It's not just the number. It depends on duration of neutropenia. Long-term is higher risk than just neutropenia for a day or two. The mechanism is very important. Destruction, as in autoimmune, is lower risk than lack of production. And that's because in destruction, there usually is a storage pool of neutrophils that haven't been destroyed yet. And another word for that is the bone marrow reserves, as I've said. And the other is barrier function. Is the skin and mucous membranes of the individual intact, or are there breaks in the skin, ulcers in the mouth that can be entry points for bacteria? And it turns out the standard definition was developed largely based on experience of cancer patients getting chemotherapy. And they have additional risks from immune suppression. Cancer chemotherapy kills all leukocytes, including lymphocytes, parts of the adaptive immune system that make antibodies, T cells. Often patients getting chemotherapy have poor nutrition. They may have central venous catheters that break the skin and are potential site for infection, organ damage, and so forth. So someone who is otherwise healthy with neutropenia has less risk than somebody who's getting chemotherapy. Indicators of risk. Obviously, someone who's getting infections is at risk for more infections. Mouth ulcers are an indication of risk in two ways. One is a break in the mucous membrane, and the other is that mouth ulcers, as many of you know, are an indication that the neutrophil count is low and ineffective. And anybody can get one or two aphthous ulcers. I get one whenever I'm stressed. Medical school is a lot of aphthous ulcers. But having many, or as one patient put it, the mother of all mouth ulcers that was the size of a nickel, is an indication that something's wrong. And then, to me, pus is good. What is pus? Pus is a collection of neutrophils. In fact, anybody here know why pus is green? This is why hospitals paint their walls pus green. Neutrophils contain an enzyme called myeloperoxidase, and myeloperoxidase is green. So you get a lot of neutrophils and you get green. So not having pus at the site of infection is bad because then the bugs aren't being controlled. So mechanisms of neutropenia. You saw this diagram of how neutrophils are made. And in severe congenital neutropenia, at least the most common forms, such as due to the Elaine gene, the myeloid precursors, the promyelocytes and myelocytes, die. And you can see this cell that's sort of falling apart by a process called apoptosis. And in cyclic, this goes back and forth back and forth. They mature and then they stop and then mature, they stop. Just allergies, not COVID. And in autoimmune, a bunch of antibodies come along and surround the mature neutrophils and whisk them off out of the blood, usually into the spleen. And so these precursors are still present in the bone marrow. And then many of you are familiar with idiopathic neutropenia. It doesn't mean you're an idiot. It means we're idiots. Doctors don't know the mechanism for this neutropenia. There's a huge overlap between idiopathic and autoimmune, because as I'll get to, the antibodies are not a great diagnostic test. And sometimes they're positive, sometimes they're negative. It doesn't actually tell you a whole lot. And in some cases, it's lack of production or failure to release cells from the bone marrow. So there they go. And then in congenital neutropenias, this is the classic where the bone marrow, this is a picture of bone marrow with a lot of early cells, the great big promyelocytes, but you don't see any neutrophils there. There are lots of genes that can contribute to neutropenia. Dr. Shimomura will be going into some of the detail. I think the main point is it's not just one gene. It's not reasonable for a doctor to send a genetic test for just one gene or two genes. They have to send what's called a panel. So treatment for congenital, the standard treatment, Dr. Dale will go into some newer developments, but the standard has been for a long time, since pioneering studies by Dr. Dale and the late Dr. Boxer, is GCSF. You're probably familiar with the risk of GCSF associated with myelodysplastic syndrome and leukemia. And in fact, anybody who Googles GCSF quickly runs into those and gets very scared. And the question is, does GCSF cause these disorders, or does treatment permit patients to live long enough to develop it? And the answer is yes, it probably has contributions in both of those mechanisms. But in the meantime, for congenital neutropenia in particular, it's life-saving. Very importantly, there are few or no cases of myelodysplasia or leukemia in patients with cyclic, idiopathic, or autoimmune neutropenia. So if you have one of those disorders, look up GCSF, Google it, you'll get scared to death by all the stories about leukemia. But in fact, with a few very rare exceptions, it doesn't apply to you. Hematopoietic stem cell transplantation, or bone marrow transplant, which Dr. Myers will be talking about this afternoon. There's still a lot of debate, and she'll go into who should be transplanted. And it's often very much an individual decision, depending on what the disorder is, what donors are available, what your acceptance of different forms of risk may be. And then gene therapy, which I'll talk about a little bit later. It's sort of like the weather. Everybody talks about gene therapy, but nobody does much about it. But in fact, it is now being used for a number of disorders, such as sickle cell disease, and it really is on the horizon for congenital neutropenia, although that horizon, we're not quite sure how long it is. And then novel drug therapies that Dr. Dale will talk about. So this is from one of the first studies of use of GCSF and congenital neutropenia, and that's where recombinant human GCSF started, and nothing happened. And day after day, nothing happened. And Dr. Bonilla and Dr. Welty, who are running that study, were about to give up when whoop, suddenly the neutrophil count started to go up. And that's because the neutrophils had to develop in the bone marrow all the way from that early stage before they could get out into the blood. So the benefits of GCSF in severe congenital neutropenia are that they prevent these complications from before the cytokine era. GCSF is also called a cytokine, meaning a hormone secreted by white blood cells for benefit of white blood cells. They had severe recurrent bacterial and fungal infections, death from sepsis in the first years of life, and a few cases of myeloid leukemia. And currently, it's the standard of care for severe congenital neutropenia, forms of cyclic, and other forms of idiopathic and autoimmune. And it's had a dramatic reduction in infections and deaths. You know, it, there are issues to GCSF, but those of us who remember the pre-GCSF era are very, very thankful for it. So I'll leave this to Dr. Myers. Um, so I'll talk about the acquired neutropenias, which are actually much more common. Those of you who may have acquired neutropenia may have been having an evaluation by a physician initially looking for infections, drugs, nutritional forms. Babies may be evaluated for neonatal alloimmune, which is sort of like Rh disease of the white cells. But those are probably in the past for anybody in this room, because if you're here, it's because you have some form of chronic, usually autoimmune or idiopathic neutropenia. In childhood, I'm a pediatrician, so I'm going to talk mostly about childhood. The median age is in infancy, but it can be earlier or later. These kids have fewer minor infections, usually upper respiratory, sometimes gingivitis, gum inflammation, but rarely any serious or invasive infections. And it usually resolves by age 5 or 10. You can see in this graph, each point on that graph is a patient who gets better, and you can see the bottom, the x-axis is age. If you go up from age 5, it's about 95%. But then there's a tail to that curve that keeps going on to higher ages, and those that persist often have some disorder in the regulation of the immune system that is making it persist. So these kids have scary low neutrophil counts, but the neutrophil count can rise at the time of stress or infection, and that's why the number of serious infections is very low. Bone marrow, which we don't usually perform, if it is done, shows lots of precursors and mature neutrophils. And the anti-neutrophil antibodies are often detected, but can have false positive and false negative results. From this study by Dr. Boxer many years ago, he showed, looking at these children, a group of 22 with positive antibodies and 14 with negative antibody tests, that 100% recovered regardless of whether they had a positive or negative antibody test. And all the other measures that he looked at were pretty much equal. So all tests have a false negative rate, meaning there probably is an antibody, but it's not detected. The Italian registry recommends repeating 3 times if it's negative, and I say don't bother because it doesn't matter. The screening tests, which is what many doctors send, has a false positive rate. There are many reasons for the antibody test to be positive without it really detecting a true antibody, which is best demonstrated not by a screening test, but by detection of antibodies specific to a protein on the neutrophil. These are labeled HNA for human neutrophil antigen 1, 2, or 3, and ruling out something called HLA antibody, which is fairly common. And maybe Dr. Myers can explain why little boys can have anti-HLA antibody. I don't understand it, but it happens. So this, for instance, shows a test at the company called Versity, where they do an antibody screen, but then look for specific antibody identification. And that's a much more reliable test. In adults, autoimmune neutropenia overlaps even more with idiopathic neutropenia, and it's more likely to be symptomatic with gum inflammation, skin and respiratory infections. It's more likely to be secondary. That means there's some underlying cause either in the immune system or a rheumatologic disorder, such as lupus or rheumatoid arthritis, which can actually appear first as neutropenia and only years later emerge full-blown as a rheumatologic disorder. So it's very important to continue screening. And often there are other antibodies, such as thyroid antibodies. So important to look for other autoimmune disorders when there's an autoimmune neutropenia, because when the immune system gets confused, it gets confused about a lot of things, not just the neutrophil. Much more common in females. And the treatment includes antibiotics for infections. We usually don't recommend prophylactic antibiotics, but sometimes it can be useful. The trouble is, for instance, one of the best prophylactic antibiotics is trimethoprim sulfa, also called Bactrim. Catch-22, that can also cause neutropenia or exacerbate neutropenia. So I usually don't use it, but then again, I'm a pediatrician. And GCSF is more likely to be indicated for adults because it can prevent serious infection, improve quality of life, but it's, as many of you have found, it's a fine balance between enough GCSF to raise a neutrophil count, but not so much as to cause bone pain. And often, in order to maintain an adequate neutrophil count, there is bone pain. And that's something that I know gets a lot of attention at this conference because it's a serious issue. And unlike childhood, where it's likely to resolve, it's more likely to be chronic in adults. So general measures. So I've been talking about drugs, but there's a lot more to care than GCSF or possible newer drugs. Good, gentle hygiene and dental care, dental complications, particularly from problems with the gums, which then cause problems with the teeth, are quite common. And we're going to have a dentist speaking tomorrow who knows much more about this than I. But it's very important to see a dentist regularly, make the kids go to a dentist regularly, and get good preventive care, because prevention, as in so many other disorders, is much better than treatment. I also strongly discourage excessive, what I call excessive precaution, social isolation. Don't let the child play with other children. Don't let the child go to school. That's not necessary, and the psychosocial harm that that does is usually more compelling than the good that it might do in terms of preventing infections that are probably going to be viral anyway. The neutropenic diet is useless. Whatever you read on the internet about the neutropenic diet is nonsense. There have been multiple studies showing that it doesn't make a difference in terms of risk of infection. And in fact, in many instances, the neutropenic diet is less nutritious than the a food safety diet. Basic, wash your vegetables before you eat them. Don't eat raw chicken, that sort of thing. Please don't eat raw chicken. very, and then, antibacterial skin cleansers that can cause irritation and breaks in skin, and, and spraying the whole house with Lysol is not necessary. Very important, encourage primary care physicians to continue all immunizations. I often encounter pediatricians who confuse neutropenia with other forms of immune deficiency where a live virus vaccine can be dangerous. Recombinant or killed virus are still safe for everybody. But I find kids way behind in immunization schedules, and there's no reason for that with neutropenia. Neutropenia does not diminish the response to vaccines, and it doesn't increase any risk from vaccines. Patients with neutropenia as part of a more generalized immune deficiency, of course, should discuss vaccines with their immunologists. So I'll finish up right on time with opening for questions, but I don't have time for right now, but we'll have a Q&A later on. Thank you.